Good morning and welcome to this meeting of the Physician-Focused Payment Model Technical Advisory Committee, known as PTAC. Welcome to the members of the public who are able to attend in person, and welcome as well to those of you participating over the phone or over the live stream. Thank you all for your interest in the meeting. We extend a special thank you to the stakeholders who have submitted the proposed model today, especially those who are participating in today's meeting. I'm Grace Terrell of Envision Genomics and Wake Forest Baptist Health. I am the Vice Chair of PTAC, and I will be chairing today's meeting. This is the PTAC's 8th public meeting that includes deliberations and voting on proposed Medicare physician-focused payment models submitted by members of the public. At our last public meeting in March, we deliberated and voted on 2 proposals related to wound care, one submitted by CHA Medical and Wound Care and another submitted by Upstream Rehabilitation. Last month, we sent a combined report containing our comments and recommendations on those proposals to the Secretary. In addition, our preliminary review teams have been working hard to review several proposals, one of which we are scheduled to deliberate and vote on today. To remind the audience, the order of activities for the proposal is as follows. First, PTAC members will make disclosures of any potential conflicts of interest. We will then announce any committee members not voting on a particular proposal. Second, discussion of each proposal will begin with a presentation from the preliminary review team, or PRT, charged with conducting a preliminary review of the proposal. After the PRT's presentation and any initial questions from PTAC members, the committee looks forward to hearing comments from the proposed submitters and the public. The committee will then deliberate on the proposal. As deliberation concludes, I will ask the committee whether they are ready to vote on the proposal. If the committee is ready to vote, each committee member will vote electronically on whether the proposal meets each of the Secretary's 10 criteria. After we vote on each criterion, we will vote on our overall recommendation to the Secretary of Health and Human Services. And finally, I will ask PTAC members to provide any specific guidance to ASPE staff on key comments they would like included in PTAC's report to the Secretary. A few reminders as we begin discussion of today's proposal. First, if any questions arise about PTAC, please reach out to staff through the PTAC at HHS.gov email. Again, that email address is PTAC at HHS.gov. We have established this process in the interest of consistency in responding to submitters and members of the public and appreciate everyone's cooperation in using it. I also want to underscore 3 things. PRT reports are reports from 3 PTAC members to the full PTAC and do not represent the consensus or position of the PTAC. PRT reports are not binding. The full PTAC may reach different conclusions from those contained in the PRT report. And finally, the PRT report is not a report to the Secretary of Health and Human Services. After this meeting, PTAC will write a new report that reflects PTAC's deliberations and decisions today, which will then be sent to the Secretary. PTAC's job is to provide the best possible comments and recommendations to the Secretary, and I expect that our discussions today will accomplish this goal. I would like to thank my PTAC colleagues, all of whom give countless hours to the careful and expert review of the proposals we receive. Thank you again for your work, and thank you to the public for participating in today's meeting in person, by a live stream, and by phone. Let's get started. The proposal we will discuss today is called Capable Provider-Focused Payment Model, which was submitted by the Johns Hopkins School of Nursing and the Stanford Clinical Excellence Research Center. PTAC members, let's start the process by introducing ourselves and at the same time read your disclosure statements on this proposal. I'll start. I'm Grace Terrell and I have nothing to disclose. At this time, I'm going to go around to clockwise.
Thanks, Grace. Jeff Bailiff, Chair of PTAC. I was formerly the Executive Vice President for Healthcare Quality and Affordability with Blue Shield of California until the end of May. Starting in June, I'm now the CEO of NewCo. It's a new company that Blue Shield is spinning off to support physicians, to provide physician support services, particularly for independent physicians. The company is 2 weeks old, and we're working on a name, so there'll be more to follow, but it won't be NewCo forever. My disclosure is Blue Shield of California has been and continues to be a multi-year financial supporter of Stanford Medicine Clinical Excellence Research Center. While I do not know or have spoken to the submitters about this proposal, nor have I been involved in any way with its creation, I recuse myself from deliberation and voting. So, Grace, I will be leaving after the disclosures.
I'm Lynn Nichols. I'm a health economist from George Mason University, and I have no conflicts.
Jennifer Weiler, I'm an emergency physician in Colorado, and I have no conflicts.
Angelo Sinopoli, Executive Vice President and Chief Clinical Officer of Prisma Health in South Carolina, and I have no conflicts.
I'm Harold Miller. I'm the President and CEO of the Center for Healthcare Quality and Payment Reform, and I have no conflicts.
Paul Casal, cardiologist, Executive Director of New York Quality Care, the ACO for New York Presbyterian, Weill Cornell, and Columbia. I have no conflicts.
I'm Bruce Steinwald. I'm a health economist here in Washington, D.C., and I have nothing to disclose, which means I have no conflicts.
And we have on the phone Dr. Kavita Patel. Can we open the lines, and is Dr. Patel going to give a disclosure?
Hi, it's Kavita Patel. I have no idea if you can hear me.
We can hear you.
Can you hear me?
Yep.
Oh, okay, great. I'll keep it short and sweet. Kavita Patel. I'm Vice President at Johns Hopkins Health System. I was not involved in the development of this proposal, but have recused myself.
All right, at this time, we're going to start the deliberation, so I will ask those who have conflicts to leave the room. So I'm now going to turn the microphone over to the lead of the preliminary review team for this proposal, Lynn Nichols, to present the PRT's findings to the full PTAC.
Thank you, Madam Chair. We're going to call this CAPABLE, but it stands for Community Aging in Place, Advancing Better Living for Elders, provider-focused payment model submitted by Johns Hopkins and Stanford Clinical Excellence Research Center. The other members of the PRT, who, of course, are both smarter than I am, are Paul Casal and Jennifer Weiler. I note they are physicians. It's entirely interesting that they picked an economist to lead this thing. It must have been a random draw. Anyway, so my first job is to go through the rules, and this is how we do this stuff, right? There's a preliminary review team actually selected by the chair every time a proposal comes in, and the staff reviews it for completeness, and then it's assigned out to this three-person PRT team. I think the only rule is there has to be at least one doc on each PRT. I will go over a proposal overview very briefly, and then we'll talk a summary about what we thought were true, talk about the key issues, and then go through the Secretary's criteria specifically. I think I just said all this. Basically, as Grace said, I'll just iterate. In fact, what the PRT is doing is kind of like a preliminary review. It's designed to make the deliberation more efficient at this level. This is the only time everyone has talked about the proposal, and certainly the PRT opinions as expressed in the report are not binding. They are merely informative, hopefully. And basically the process is the proposal is reviewed by staff. We then look at it in detail. Typically, and in this case we did, ask questions of the submitter to clarify things that we didn't quite understand. And also staff and their very capable contractors at NORC will give us supporting information, both things they know we ought to know and as well as questions we may have for them. And they will sometimes do data analyses as well. And as Grace said, this report is not binding on PTAC, but it is here to help us reach conclusions efficiently. So this, first of all, comes with a history. This CAPABLE proposal was based on a pilot that was funded under a Healthcare Innovation Award, and it also has been evaluated as an NIH-funded randomized controlled trial, so it comes with a good pedigree. It's designed to improve the functional ability of older adults with chronic conditions and with functional limitations. When you think about the way the APM structure is set up in the statute, the APM entity would likely be an accountable care organization or some kind of equivalent entity. The intervention or the actual essence of the program is listed on the left-hand side there. Think about it as a time-limited intervention. There will be 10 home sessions, 60 to 90 minutes each, 6 with an occupational therapist, 4 with a registered nurse, over a course of 4 to 5 months. In some ways, the key innovation is the handy worker, which is basically somebody who knows how to fix stuff, and at the direction of the OT would perform what we can call limited home repairs, which of course can be incredibly helpful for preventing falls and making daily life much more easy for the resident. And of course, all these sessions do indeed have a patient-centered focus. In order to be eligible for the program, the applicants suggested that there should be some kind of either a self-reported or a positive screen for at least one limitation in activity of daily living. Other features may be a recent stay or anything related to a fall or in-home accidents, debilitating chronic pain, polypharmacy, et cetera. Need to be living in the community, have minimal cognitive impairment because motivational interviewing is a big part of this, and not be terminally ill. And while the applicants, I thought, made clear that this could benefit almost everybody who satisfies those clinical conditions, given the nature of our need to target things, they thought folks under 200% of poverty were the ones that should be eligible for it out of the box. The payment that was proposed by the applicants is essentially a flat fee, like a bundle, that was proposed originally as not risk adjusted. There's an asterisk there, and that is to remind me that in the back and forth between the PRT and the applicants, they agreed that they could certainly imagine that one might want to risk adjust that. The reason they proposed it as not risk adjusted was because the cost of providing the capable services was relatively easy to predict, and I think had been replicated in a number of different examples around the country. So they're pretty confident at this 2,882 number. Interesting number, but anyway, so that seems to be pretty easy to document, but they proposed it as this flat fee for these services. It's important to understand, as if anyone in this building did not, that traditional fee-for-service doesn't pay for all the stuff that Capable has envisioned in the intervention, and that's essentially the problem. Things that might indeed be clinically useful are not currently in the fee schedule, and of course, that means that it comes down to fee-for-service. Medicare does not cover in-home modifications. Medicare Advantage plans have a little more freedom, of course, than fee-for-service Medicare at the moment, but they're still bound by primarily health-related, and so the serious conclusion was Capable is going to expand services beyond what is today available, and that's why it's a proposed innovation payment model. The model does not address total cost of care or risk sharing. The submitters are basically focused on providing these services to folks in their home. They believe, in fact, there's some evidence that there would be cost consequences over time. We'll talk about that in a little more detail later on, but that was not part of the proposal to talk about total cost of care or risk sharing. And you could certainly imagine that this could be easily worked into an ACO framework, as the ACO is sort of the accountable community, accountable organization. Like I said, the asterisks mean the submitter in the responses to our questions indicated a willingness to modify their proposal, but as we will discuss in a little more detail, we felt like, and I think they would agree, that there were still many details that would need to be worked out, and so that's part of what the judgment had to be. So as far as evidence, there is a fair bit of evidence that there were significant reductions in functional limitations at 5 months after baseline, but the published reports would suggest there was no significant difference in functional limitations at 12 months. The HCI evaluation found no significant difference on spending, either Medicare or Medicaid, although the samples were small, and so they clearly were underpowered. There have been organizations who very strongly support Capable. I think we got 7 letters of support. I can't remember exactly, but it was, you know, a robust set, and from people who have respect around the country. And it's true that there are 18 different versions of this going on around the country, and so clearly a lot of people are impressed with the model. Now, this is a summary of our judgments of each of the Secretary's criteria as specified in the law. And you can see that, did pretty well, but it did not meet payment methodology, which is one of our high priority. We also had concerns about integration and care coordination, although that was not unanimous in the PRT. And then we felt unanimously that it did not meet on health information technology. So basically, what we felt were the major issues are, it's definitely innovative. It's definitely addressing a problem that is not currently well managed in the Medicare program. And for all those reasons, it's definitely worthy of consideration. It's got a lot of support and so forth. However, it wasn't entirely clear to me or to us that we really need an alternative payment model to do this. That is to say, if Bob Berenson were here, if the codes were adjusted appropriately, that is to say the CPT codes, one could imagine this being taken care of in a fee-for-service nature. We talked about that with them, and since none of us, since we have no power to compel codes to be constructed, and obviously the applicants don't either, that's why they proposed this APM. And I will say they definitely were willing to entertain a modification proposal from the flat bundled, no risk adjustment version that they proposed. However, there still would require CMS to do a fair bit of developmental work, and as our committee has learned, their bandwidth is limited, and so that's a high price to pay. Some of the services are currently paid through Medicaid waivers and so forth. However, like I said, we don't really have authority to require that in fee-for-service Medicare. We were concerned about the lack of specific physician interactions. This is very much a contained intervention for non-physicians. Obviously, there could be communication, and the submitters talked about examples of how that could happen, but we felt like there was insufficient detail, and that was why the majority of our PRT thought it did not satisfy the care coordination integration criterion. And the HIT problem fundamentally came from while EPIC exists, and EPIC has a nice little module that could facilitate physicians getting access to the information recorded by the capable staff. There was no requirement for such information exchange, and if you don't have EPIC, then there was no plan really for trying to figure that out. So that's why we felt like that did not get met. So on scope, there's no question. This is not being covered by other programs, and it would be an innovative recognition of the fact that some things outside the specific clinical scope could actually have clinical impact, and so in that sense, we felt like it met the criterion. Quality and cost, there was enough evidence, in our view, that quality was improved even if cost might not have been reduced according to the evaluations that were done. And it's unambiguously true that if quality is improved and cost is not, then that also is worthy of consideration. So we felt like criterion 2 was satisfied. Payment methodology was the one where we thought they're really, again, they understand the importance of risk sharing and accountability, but we felt like the flat payment not being risk adjusted was a problem. They're open to thinking about how to do that in a different way, but those details were not able to be specified. And we really felt like in a fundamental sense, it's going to require a fair bit of work on CMS staff part, and that's why we thought this did, as written and as modified, did not satisfy the standards we'd like to set for payment methodology. Value over volume, we certainly agree that we thought unanimously improving the quality of care for these folks and the quality of their lives would make it satisfy this criteria. It is, if not flexible, because go to people's homes and figure out what they need. It certainly can be evaluated. The control groups that were constructed for some of the evaluations were small, and that's why the power wasn't so great, but it doesn't mean it couldn't be done. It's quite simple to imagine how that could be done. Care coordination I've talked about a couple of times. I'll just say the fundamental problem there, we thought, was a lack of very explicit coordination with physician oversight. Patient choice, no question, satisfies that. Patient safety, we felt pretty good about that. The whole intent is to improve safety of living at home. And finally, as I spoke, HIT, there was no plan B if it didn't have EPIC, and so we felt like it did not meet those criteria. So let me stop there and have my physician colleagues add anything they would like to clarify for expanding.
Sure. Thanks, Len, for that review. And yeah, I would just really just highlight what you've already said. I think the challenges are, as you stated, is there a need for an APM for this to be implemented, or is there alternative way? And as already alluded to, there are many other places where this is being done through other funding sources. And as you also highlighted, the Medicare Advantage has expanded, so in 2019 to potentially allow this. So you could see, I think there's no question that it benefits the beneficiaries. I think the challenge is, do we need a payment model, an alternative payment model in order to have this implemented? And yeah, I think that's where the biggest challenge is.
Yes, thank you to Paul and Len for summarizing our thoughts. Clearly, this model has been impressive and successful, and its scalability across the United States in pilot programs, again, is impressive, that this can be adapted not only at the macro system, but also within patients' homes. So it's the right thing to do for patients and in a really important population. That said, the three areas, just to highlight again, the payment methodology of creating an APM is one that we struggled with because even though it's not currently paid in fee-for-service, we'd like to hear in the comment period really understanding why this can't be an expansion of a Medicare Advantage program or why this can't be adapted into fee-for-service, even though that lift is hard. We have an opportunity to influence but not mandate those other programs, and why specifically an APM is one where this program is one that would be most successful from a payment perspective. The next is around care coordination and integration with physician practice. We appreciated the comments that came back, but really a detailed understanding of how this might be part of a care plan for a patient would be helpful for us to hear about. And then finally, although Epic, yes, is a dominant player in the electronic health record space, there obviously are others. So really understanding the digital care coordination aspect would be important. Thank you.
So if there are any questions from the committee for the PRT members, we will try to continue our practice that we've been doing the last couple of meetings of trying to limit questions to the PRT committee that might best be answered by the actual submitters themselves, but we will do some. So I'm going to first go with Bruce.
Yeah, thanks. Nice presentation. It's pretty clear. About your asterisk, I understood from the proposal that the submitter didn't really think it was necessary to risk adjust because they thought the costs were fairly constant across different kinds of patients, and yet you had stated that you weren't sure that an ACO would be willing to participate if there were no risk adjustment. So my question is, why did you come to that conclusion if the presenter presented evidence that the costs were fairly constant? Or did I get that?
Really good question, Bruce, and I expect no less from my fellow economist. I'll just say, look, so the proposal, as I understand it, was to provide services in the home for which the cost is relatively predictable. Boom, this is it. That's why they proposed a flat fee. Our point of view is an alternative payment model is meant to engender some kind of attempt to get at total cost of care, some kind of attempt to actually create, if you will, an incentive to reduce total cost of care. And this insertion, while it might very well have that outcome, and in some cases was shown to, in other cases not so much, and our thought was that an APM should be more globally focused, and therefore we thought in a world where while the cost of capable is not going to vary by patient, the cost of those patients in the rest of the system will vary a lot, and that's why we thought an ACO or any kind of sort of risk-focused entity is going to want to have a risk-adjusted payment. So that's where that all came from.
Are you wanting to respond to that, or is this, okay, Jennifer?
I would also add from the clinical perspective, when we think about how this APM might be scaled to other patient populations, this is about keeping seniors in their home safely. But there were from a pilot perspective, there was a necessary scoping of the patient population from an inclusion-exclusion criteria. So we also discussed, in order to meet Medicare's expectation around high impact areas in total spend, that this program may have to be scaled to a larger patient population. And if that were to happen, that would mean sicker patients, trying to keep them at home. So there would need to be some risk. Our opinion was there needed to be some consideration for risk adjustment.
Mr. Miller.
Thanks. I just wondered if you could elaborate just a little bit more on your interpretation of the studies, because you've all said you think it's a really good program. And when I look at it, I think, really desirable set of services, but a question is, does it in fact save money, or is it just budget neutral or whatever? And I looked at the studies, but probably not in as much detail as you did. And I'm sort of wondering, like, what did you conclude from them? Were all the indications were that it did save money, but they were underpowered? And I guess part two of the question is, to what extent do you think that the results are in fact extensible to a broader population, as opposed to they happen to pick, except for the one randomized trial, they happen to pick people who would be potentially benefit from this, and that if one started to do this more broadly, particularly if you had a billing code for it, that all of a sudden you would start to get lots of people who didn't really need it quite as much, but were getting it because it would generate income?
I'll let my clinicians speak to the sort of broader population question. I'll speak specifically to the evaluations, Harold. The HCIA evaluation showed that it did indeed improve functional status after 5 months, and I take that as quality improvement for the person, but it did not show a savings in cost. And the other studies, Medicare and Medicaid, so forth, did not find impact on costs that were statistically significant. There was sometimes, but not powered enough or not significant in the standard way of thinking about those things. So the way I would conclude it is, it's a program that's highly likely to improve the health and well-being of the people, but not necessarily to save money. In my view, the statute says either improve cost or lower quality, improve quality or lower cost, or both. This does one without hurting the other, so it did not increase cost.
Just to follow up, though, when I looked at the three studies that were, I think it was 3 studies that were quoted, there was one that showed sort of basically almost no change in spending, sort of a small increase. The other one showed decrease, but with confidence intervals across 0. So I'm wondering whether there was any, did you draw any interpretation that said that the actual savings, the mean savings that they showed, seemed sensible given the other kinds of things that were showing up, that they in fact did see reductions in hospitalizations, et cetera, and it wasn't some other aberration? I'm just trying to sort of sort out the issue of, the challenge is always statistical significance in an underpowered study, right? What do we know? So you have to look for other things that might tell you whether all the other signals are sort of pointing in the right direction. And I just wondered if you saw anything else that says to you, yes, I think it's probably saves money, but they're underpowered, or whether I think that could have just been a random effect of the particular project.
Speak for myself, my interpretation of the studies is that it very likely improves functional status. It very likely does not statistically affect cost. And the rest of it is commentary, really.
I just
Yeah,
have,
I'm sorry. I was just going to add, because I was getting a nod from Len to say something. Yeah, I had the same interpretation. I think the cost, I don't see this in the current as cost savings. I think the benefit is keeping people in their home, and how you figure out if that's cost savings or not versus just quality of life is really where I focused on particularly.
I guess I'm going to answer just a little bit differently, and we had this conversation internally, in that Does it improve functional status? Yes. Have other studies shown that improved functional status means decreased visits to emergency departments and inpatient hospitalizations? Yes. They started to go there from an economic modeling perspective, but didn't go the full way. So from the clinical perspective, it makes sense that if we can keep people in their home and prevent them from falling, that there will be cost savings. But the studies that were made as reference have shown that correlation, but this particular pilot does not yet have the power to show that in a robust way. But from a clinical perspective, for me, it makes sense that it could, but that's one of the challenges that would need to be addressed in order to affirm that there not only is this quality improvement, but an opportunity for cost savings long-term.
I have a question that's really about our scope. So we're supposed to be the physician-focused payment model technical advisory committee, and within the context of that, we now know that MACRA includes a broader range of clinicians, including occupational therapists. So I can understand the thinking about this within the context of that as a provider type, that we can look at alternative payment models and therefore evaluate them with respect to whether they ought to be recommended to the secretary. But one of the things that you all were didn't score very highly was related to coordination with physician practices. So is this something that really ought to be within our scope? Did you all talk about that at all at the committee level or not? This gets kind of back into my concern sometimes about payment models versus care models. Everything that I've heard you all say and what we are asking about has to do with an excellence of a care model that may or may not be cost neutral. But is it within the scope of what we're supposed to be commenting on? So did you all have that conversation at all with respect to our scope as opposed to this proposal?
So let me make sure I understand the question, Grace. Are you saying that you're asking the question, is this physician-focused enough to be in our purview? Or are you saying, did we judge this thing harshly because we didn't see enough docs running around in Criterion 7?
Is this a physician-focused payment model or not? I mean, if it is, it is, but if it's not, I just wondered if you tackled that issue at all.
I think staff helped us think about this, if I remember correctly. Sarah, I'm not blaming you. I'm just saying I believe we asked the question, and they said, oh, but Lynn, the statute says it's not just physicians. And so I think we settled that pretty quick. Well, that's the answer to the question.
That's all I wanted to know. Are there any other questions from the committee members? Okay. Well, if not, I'm going to invite our submitters to come to the table up here. We are going to let you all have your own say about this. And then afterwards, the committee will have an opportunity to ask you questions directly, and we appreciate that. So which one of you is, if you will introduce yourselves, and then whichever is going to speak first. Cut on the...
I'm Sarah Zanton. I'm a professor at the Johns Hopkins University School of Nursing and the School of Public Health.
I am Kendall Cannon. I'm an internal medicine physician as well as a clinical instructor at Stanford University. And I also am the medical director and primary care physician for a PACE program with WellBe Health.
Okay.
Great. Well, thank you so much. It's such an honor to be here. Thank you for the work of the PRT and for just being able to have this opportunity. So addressing the function of older adults is imperative, with 10,000 people turning 65 each day currently. And as Dr. Weiler alluded to, physical function is a modifiable risk factor for many bad outcomes, including nursing home placement and preventable hospitalizations. I'm a nurse practitioner with a PhD who provided a decade of house calls, and my patients often greeted me on their hands and knees because that's how they got around their home, or dropped keys from the second floor because they were trapped on the second floor, and I would find the keys in the grass and let myself in. I also had a 101-year-old who had to drop out of her wheelchair onto her knees to get into her kitchen because her doorway of her kitchen wasn't broad enough. So, this happens every day, and I'm so pleased that we're able to bring forth the importance of the scope for traditional Medicare. And you've heard about Capable from the excellent report, and also that there's been 10 years of research. And HUD also has researched Capable along with the Weinberg Foundation. They funded the first replication. It's now in 27 places in 13 states, including CMS recently approved adding it to the Medicaid waiver for Massachusetts for people who want to age at home. And also, important to part of your discussion prior, our CMI asked us to go through the PTAC process. They said this will be the next logical step for Capable. And also, their evaluators that were assigned to us from being part of CMMI demonstration project published in Health Affairs in 2016 cost savings that was $2,700 per quarter per patient for 8 quarters, and Capable costs about $2,800. So from that analysis, it would seem that it saves about 7 times what it costs. I understand that there's research all over the place because the samples are small, but I think from a conceptual point of view and from some of the data, it looks like it saves more than it costs. I also, data you don't have is Trinity, the accountable care organization that's multi-state. They adopted Capable as an innovation to try out in one place, which was Muskegon, Michigan. And we recently presented those results together with them at Academy Health. And there it saved more than it cost, even though they had a much smaller dose, if you will. The handyman was more about $120 than $1,200. And they found reduced ER, reduced admissions, and lower length of stay compared to a matched comparison group of the rest of their ACO. And then subsequent to those data, Trinity voted to scale it to 2 new places. So I think, there is good reason to think that that it saves money, although it's not a slam dunk yet with the data we have so far. I also just wanted to thank you for your words about our flexibility. The whole model is flexible, and we are flexible people as well, and happy to consider a graduated kind of payment in terms of the frailty and complexity of the participants. As Dr. Steinwald mentioned, we had just envisioned it kind of the way you would envision a flu shot, right? It's just a thing, and it doesn't need modeling for how much you would pay for it, but it does make sense that as more frail and complex people come into it, that you might want to add another nurse visit. So I think that makes a lot of sense, and we think the best outcome would be for PTAC, not to tell you what to do, but that I believe there's several options what PTAC can advise, and one of them, I believe, is option C, which is recommending a limited scale, right? Testing it out a little bit more, and then we would all learn more about what makes sense in terms of costs and savings and how to pay for it. In terms of the coordination, I think in your binders you all have the additional information that we presented, and some of that does address the coordination with primary care in a more robust way. And we started as research separate from primary care, and needed HIPAA waivers to be able to talk with primary care. Now that more and more places are adopting it, and not just with Epic, but also with Epic, the primary care providers are much more involved, and there's some quotations from some primary care providers showing how it's distinct and separate, but so needed and useful to address function. Even just buying a refrigerator for someone who needs insulin, right? That you're not going to do that in primary care, but it's capable. The handyman budget is fungible across things, so it can be items or home repair. And we also, in the additional information, talked about different ways of interoperability with health IT. So, you're welcome to refer to that. And Secretary Azar often mentions that he's the Secretary of Health and Human Services. And Capable fits squarely in this stream of innovation of not just looking at diseases, but looking at the total health of people. And you're likely aware that the RAISE Act for caregivers, which was passed in 2018, requires the Secretary to develop and maintain a strategy to help caregivers across the country who are under a lot of strain, and Capable fits nicely into a strategy like that. Before I introduce Dr. Cannon, I wanted to just leave you with a story of a Capable participant who finished recently, who's a veteran. He's in a wheelchair. He has end-stage renal failure. He's on dialysis. And when we got to him, he had a completely flat affect, a depressed affect, was in a lot of chronic pain, and never left his home except for dialysis. He had a grown grandson who would come over and help him some, and his favorite thing he liked to do was to sit on his back stoop to listen to the birds, and he couldn't do that in the wheelchair. His grandson would have to lift him up. And in identifying his goals, he wanted to work on his pain, and he wanted to be able to shave standing up. Currently, he's shaved in a wheelchair, and the gunk of it and the cream just dribbled into his lap. And, you know, that may seem like a small thing to those of us who are able to take the train or the plane and get here, but that was really big to him. Those aren't things you would ask in primary care, right? You wouldn't ask, how are you shaving currently, right? Or can you get outside, out into your backyard? But we addressed his pain, his strength and balance. We put grab bars around his sink. By the end, because of those, he could stand to shave, and that was a huge thing for him. We put grab bars around his back entrance, and because of his strength and balance and the grab bars, he could get out into the back stoop and listen there without needing his grandson. He no longer has a flat affect. He's got a twinkle in his eyes, and now he's going out and doing other things besides just dialysis. And speaking as a primary care provider, if he had come into my office for a 20-minute visit in the beginning when he was depressed and in pain, not going anywhere, I wouldn't have thought I could do much for him. You know, but after an intervention like this, he's more engaged, he's more able, he feels more dignified, and then primary care can do more for some of his other issues. So he went from being a socially isolated, depressed, and in pain person to someone who can navigate his home and his outside environment with confidence. So I'd like to introduce my colleague, Dr. Kendall Cannon. She's, as she mentioned, where she's been, and she contacted me after looking at all the programs for an aging society and thought that Capable was worth more study.
So multiple people have asked me, how did Stanford get involved in this? Because this is very much Sarah Stanton and Johns Hopkins project. The Clinical Excellence Research Center is kind of a think tank for value-based care and has fellows each year to study healthcare innovation and design with the primary goal of lowering costs and improving or maintaining quality and patient experience. And so our year's topic was how to improve care in late life. So we spent an entire year researching both what is that definition, what does late life mean, which we came to define as the intersection between multiple chronic conditions, functional limitations. What are the primary needs for that population? And completed a very extensive literature review. And then from there, tried to find everything we could, both within industry, within academia, that served and met those needs. And I have to say, by far, Capable had the best cost-saving data, although, as several people have mentioned, some of it is a little bit harder to interpret, but also had, for me as a clinician, getting to learn more about Capable ended up changing the way I think through medical care in terms of integrating other services, and as a primary care doctor, why it's so important to have and use the other people on the team, which to me was this Capable team. And so that was, for me, one of the biggest reasons I ended up actually in PACE, and changing my philosophy was because of Capable. And so very much understand there's not a doctor on the roll call for Capable, but changed the way I practice.
We've exceeded a little bit your 10 minutes, so I'm going to, no worries, but I'm going to, at this point, open it up for my commissioner colleagues to ask questions. Mr. Miller, you've got a question?
I do, several actually. First question, I guess, is the question about risk adjustment, I think there's a couple of different purposes to risk adjustment. One is if you need different resources to be able to deliver a service for different patients. The other is if you're accountable for outcomes and the outcome risk differs. In this case, though, I guess I'm curious, you say it basically costs $2,882 for everybody because it looks to me like you follow, in general, a fixed protocol with everyone. But I wonder whether that's necessary. And in fact, if in fact some patients could get it for less, then it would be a more saleable program for many people. If you said, you know, the man in the wheelchair doesn't need 5 months of RN and OT visits, they need an OT assessment and the handyman, and look what a transformation that will make. So I'm wondering, first of all, whether you've thought about that, whether there is in fact a way to stratify the patients, not to say, yes, if it's risk adjusted, we'll do more for some people, but whether some people could do quite well with just, less.
Sure, thank you for that question. So certainly there could be less. The way it's designed is that the older adult picks 3 different goals they want to work on with the nurse and 3 different goals they want to work on with the OT. And those, they address a goal, after the initial assessment, they address a goal on a monthly visit for those times. So someone could have fewer goals, unless you're going to have really long visits and where the cognitive intake is going to be less, you'd have to have fewer goals, which could completely happen. And in fact, in the Trinity replication, they started with a community health worker and worked on some of the goals, and then did have fewer visits, and that could certainly happen as well.
So you're saying in some cases it could be less and there could be a different level of payment.
Absolutely.
Second question is, could you explain to me how you see this interacting with home health? Many of these patients, and I'd be interested in what your experience is in terms of how many of them would qualify for home health services. And I was concerned, I guess, the concern was that we have the RN and the OT from home health showing up in the house, as well as the capable RN and OT showing up in the house. And the second is that if in fact the service was desirable, home health could pay for it. They're not restricted in terms of what they can spend money on. They get a prospective payment. They wouldn't necessarily want to spend more money on this under the current model, but they might. And so tell me how you see this working with home health and coordinating.
Yeah, so some of the places that are adopting Capable are home health agencies, and in fact, I think one of the people registered to give a public comment is an occupational therapist at a home health agency in Denver that has been doing a wonderful job with Capable. So home health, what Medicare calls skilled care, is different than Capable. It is with a specific something in mind, like wound care or new diabetic teaching, it certainly could work through that if the skilled care definition was a little bit different. But just as a small example, an OT cannot open a case in skilled care, and they always do in Capable. So that there would have to be some tweaks. Also, we've hired people from home health, and there's a real mind shift. Capable is all about the older adult, what they want to be able to do, and that all of the ideas come from them in terms of what they want to do. The clinician uses their pattern recognition and clinical judgment to help brainstorm with them. But when we hire people from home health, they really have to be retrained. It's a different model. So that's certainly possible, but it's not the same.
But it wouldn't necessarily be a bad thing to have it more integrated, and this could potentially be something under home health. Third question is, I wasn't sure I understood this is related to the second question, who you envisioned ordering this service. Because there was mentions in here of physicians submitting a billing code, but then we'll let the primary care physician know. And so I wasn't clear on, does a physician order this service, or are there RN, OT, handyman teams sort of cruising around looking for patients who might need their help and say, hey, you look like your porch needs fixed. Hey, we got a service for you. How would that work?
We were envisioning a primary care provider ordering it, and right now nurse practitioners can't order home health, as you know, and so in the current setup, probably that would be a physician, although it probably makes as much sense for also nurse practitioners to be able to. Just addressing your second more comic point, currently, there are capable programs that are started by Habitat for Humanity, for example, and they go to their wait list. Or, there are, but for what we're talking about today with Medicare, it would be starting from a clinical side.
Okay, final question. There were a couple of mentions in your proposal about when you were talking about the model, et cetera, and I'm quoting from page 9 to page 10, that there would need to be strict limitations on quality and very close measurement of quality. And I wonder if you could elaborate what you meant by that in terms of what you thought would be the quality problems that might arise unless it was strictly limited and very closely monitored.
Well, I don't know if you want to talk about that also, but okay, go ahead.
So one of the concerns that my team had was that this potentially could turn into, by creating a payment model, roving herds of nurses and OTs and handymen looking for work.
Herds, yeah. Right.
And so we felt like in order to maintain the quality that was shown, the improvement in the ADLs, the improvements and the decrease in hospitalizations and nursing home visits, that those would have to continue to be measured. You couldn't just put this out there as like a, hey, here's a new program. And we also saw it sort of in the sense of concern, the way hospice, when it switched over, became much more focused on that financial part rather than on improving the quality of care, although it does both.
So just to summarize, so your concern would be that there could be overuse of the service unless there was some way to show that it was actually being focused on the people whom it would benefit. Okay, thanks.
Angelo?
I think Harold asked most of my questions, and I think you may have answered most of them, but still a little bit curious as to how you're thinking about this as being an alternative payment model as opposed to services to PACE, who's already taking full risk, or to an ACO who may be taking full risk, and why it's not just a service that's integrated within the care model and the care management team.
So I'll start, and you can add if you want. Certainly, we've shown by the partial scaling that it is possible to offer in different ways, but because traditional Medicare is still the bulk of service provision, that it would be a way of scaling it much faster, that if we just relied on Medicare Advantage and the very most forward-looking ACOs, this will be, these problems, like the person in the wheelchair in pain, will take a lot longer to reach kind of saturation and scope.
So I have a question, and it's about the criteria from which you selected handyman. There's not, as far as I know, a lot of literature on that in the medical literature about what would make a good handyman. Certainly, we've got occupational therapists that are licensed and governed and are professional. Certainly, that's true for registered nurses, but a handyman is kind of or a handy person is kind of a pretty vague job description. And the types of people who have those skills might be quite variable in terms of their background. So I could envision a dystopic future where it's not hordes of handymen and nurses running around, but suddenly everybody's a handyman. And so as you're thinking about bringing in new services, I suppose, to the healthcare ecosystem, how are you all thinking about those non-traditional roles and making sure that there's no fraud, that there's competency, and that it also doesn't actually inflate costs, where suddenly everything out there, like diabetic shoes, now has to cost a particular price?
That's a great question, thank you. So some of the capable sites have hired their own handy person, and they've made sure that they are licensed and bonded, and they're under kind of their clinical supervision in a way, and the handy person implements a work order that the occupational therapist makes up, or, addresses, and it's based by the person's goals. And so it's not, so it's kind of under the occupational therapist's scope in a way. The second thing is that I'm not sure as much in rural America, but in urban America, there's very often nonprofits that have been long established that do small home repairs for low-income people, and a lot of the partners we've had have hired those, and with licensed and bonded and drug testing, and in fact the one that we work with in Baltimore actually sends in 2 people, one who's getting job training skills through AmeriCorps and one who's a more senior contractor.
And just one more quick question. The cost of handrails they may put up, or ramps, or whatever the particular thing does, that would strike me in a lot of cases being much more expensive than, $1,200. So where were those costs accounted for in this model? And was there variation in that?
Thank you. So we've published a paper that I'm happy to furnish the PTAC about the kinds of modifications and how much they cost on average. In our randomized control trial, on average, 14 different things per house were done for that amount of money. They were often very small things, like $7 bed risers that go into the 4 corners of the bed to make it taller so it's easier to get out of, or a cutting board. The budget is not big enough for ramps, but grab bars and extra banisters cost about $80 parts and labor.
So this was a total bundle then?
Mm-hmm.
Okay. Jennifer?
So we previously raised some concerns about integration and care coordination, so I want to prompt you to give some thoughts on that. So these services are triggered by a physician order. What in your pilots, or what is your recommendation, or what is your expectation around how this fits into managing health of a patient and that care coordination, and then specifically the health information communication component?
Thank you. So, right, so as we mentioned, this is kind of an adjunct to primary care, and certainly not a replacement, and that the provider would order it, and then would be getting updates from the care team, and that it doesn't exist with, so some primary care providers already have case management, and in which case that case manager would be being kept up to date very often. And we have a whole case example of a woman in Maine, and with a table of before and after capable. I think Kendall and I were talking briefly beforehand, and I think so much of it has to do with decreasing primary care burden. That everyone in primary care is overworked as it is and has really short visits, and to take care of some of these other things that lead to hospitalizations or even just more calls to the primary care team is part of that, if you want to.
In terms of the information exchange with primary care, again, was also one of my concerns and my team's concern. Epic, the fact that they were able to create a module in Epic kind of told me that we could at least expand that to other EMR systems. And so I don't think we ever intended in our proposal to say Epic was the one and only, just that they had made one and it works, and so it could be duplicated. Also, the idea that as a primary care physician, I don't have the time to do the type of motivational interviewing and goal assessment that this team does. And so if they can come out of these visits with a goal, some of them are functional, some of them are healthcare focused, then I can supplement that, whether it's polypharmacy is one of the major issues. People are primed to then want to talk about, oh, we're gonna stop these medications. And so a lot of what the capable team does is educate the patients on how to speak to a primary care doc, how to present themselves, how to share their ideas. And so for me, really that increased patient interaction both improved the clinician experience and the patient experience.
We provide a health passport that has a number of things in it, but part of it has questions that you wanted to ask your doctor. And so even if someone feels too shy to ask them, they can at least hand it over and say. So there's also care coordination, just old school on paper, as well as on the EHR. And since it has been integrated into the EHR in some sites, we hear and we understand that, providers are messaging through that to the capable OT or the capable nurse saying, oh, I see that you're working on this goal, I'll reinforce that in my visit, and that coordination has been happening.
So at non-Epic sites, it obviously makes sense if, I'm going to get very operational, but just to make sure that we understand, that they have Epic access, they can provide a report, it's all within one ecosystem. Is your expectation in sites that don't have that digital platform, that there is a traditional consult note? How is the primary care provider knowing what the assessments are, including the ADLs, IADLs, and PHQ-85 scores that you mentioned on page 2? Where is that information then being transferred back to the primary care provider? Is this only currently pre-post as described, or is there an expectation that this is a bundled consult? How would this happen if it was not in the current Epic platform as described?
I think we're very open to how that should work, and I think different primary care practices would probably have different views about how that should work. And we proposed a model where, like, after the second visit, we let the primary care provider know about the goals, and but I think after could work fine too. We in our research, what we ended up doing was after we were done with after the 4 months, we wrote what the goals were, whether they were achieved, what else they still want to work on, and. But I mean, I hesitate to say this is how it has to be for the whole country. But the principle of sharing back and that it's under the primary care provider's purview and doing it in the way that makes the most sense from their own health IT, I think is probably as specific as it makes sense to get, unless I'm misunderstanding your question.
I also wanted to share, I think that part of the problem answering that question is that right now a lot of the capable programs are being run through housing or these different ways, and so you're trying to get information back to a PCP who doesn't even know it exists. And so there's different, depending on who the doc is, different ways you can get information to those doctors. Sometimes the best way is through a case manager, sometimes the best way is a consult note, sometimes the best way is a phone call, and the capable RNs have done all of those different things and tried all of them in order to get to it. I think the idea as an advanced payment model was that this would be, it adds that medical component, and so then would actually be thought about by clinicians, and so facilitate the communication, as opposed to just the trials that are going on and trying to kind of spread it as is.
We have a paper published about the primary care provider feedback loop that I'm happy to provide the committee. And the capable nurses up to that point had done a number of phone calls, emails, hard copy letters for the chart, and different providers preferred different things.
Harold?
One more question. I'm thinking about, so if one were to try to do this, how would one implement and pay for it? And I could see several different potential approaches that I'd just be interested in your reactions to. So one is CMS currently has a comprehensive primary care plus demonstration. And in that model, the primary care physicians get an additional care management payment with which they can do the kind of things that Kendall said I can't ordinarily do. They could hire nurses. The amounts of those payments would probably not be enough to support the service, at least as you costed it, although it might be if it could be done for some patients less expensively. But if you would say there is a payment for this, then potentially you could say, a primary care physician could now accept for this kind of patient that they would get this kind of payment and they could deliver this kind of service for it, and then they would also be accountable for the fact that it would in fact keep patients out of the hospital. So that's one model, is that it could sort of be an enhancement to that. Another model is CMMI has an independence at home demonstration, where there are physician practices, groups that have decided to focus on trying to keep a patient population at home, but it's a pure shared savings model now. And you might say, these are groups that are focused on trying to keep a patient population at home, and this would be a useful service to add to them, and they're already, upside accountable and maybe downside accountable for that. You don't have to be a whole ACO, but you're focused on this particular, and if you look at the criteria for those patients, they're very similar to what you've suggested. Third model would be that you make this an adjunct to the home health prospective payment system, and you would say, particularly under the new system, a home health agency can do this. They get a prospective payment. When I looked at the numbers were on the order under the current system, it's on the order of $3,000 or so for a 60-day period. Under the new system, it's going to be about $2,000 base payment for a 30-day period. And then if you have functional status limitations, comorbidities, you get a higher payment. So in fact, again, it seems to me that this model might fit there if there were some encouragement to do it, and it would be a logical thing to think that home health agencies who employ RNs and OTs could potentially do this. Or you could make it a free-for-all and say that anybody who wants to go out and start doing the service can, bill for it. If you could just give some reaction to where you think is feasible. I mean, if those options were available, would primary care physicians say, who are already interested in doing care management, jump up and say, yes, I'd like to do this, or too complicated? They might certainly contract with a home health agency, but it would flow through the primary care physician. Or do you think it's better if it's sort of integrated with home health and viewed as yet one more thing that a primary care physician can refer to home health and then hold the home health agency accountable?
Do you want to address that?
So a couple of thoughts on that. In terms of the primary care being responsible for, hiring and coordinating the OT, the RN, and the handy person, that's not really our skill set. And so my thought was that it could be seen more as an adjunct. My concern, I think that it does work within home health. My concern is that having worked with multiple home health agencies, what this program is very different. And so to try to say that we would just put this with a home health team, it would change what I believe to be the most efficacious parts of the model, the person-centered goals, the motivational interviewing, because these people are thinking very differently than you do for a typical OT or a typical skilled RN experience. I would worry that you would lose the benefit.
But that said, there are home health agencies that are successfully doing it. They just have a special team, kind of like they might have a hospice team that thinks differently than the regular skilled health team. And so, to me, they all sound good, and thank you for the roadmap, I would say. And I think that...
Do you think it would be good for home health to be more patient-centered and motivational interviewing-oriented, et cetera, than it is today?
It's part, yes. I mean, I'm sure we both would say that. But also, their visits are longer. Typically you do 2 or 3 visits in a day of this than the 8 or 9 you might do in home health, right? So it would take a team, I think a capable team within the home health, but it could certainly work.
Lynn?
Madam Chair, I would like to call attention to, I forgot something that's really important.
Uh-oh.
Yeah, I screwed up. So I just wanted to point out, in particular, Harold, in relation to your first question about the interpretation of the studies, I was supposed to, but forgot to make clear that the kind of most interesting one, the randomized trial study, the control group was not patients who got nothing. It was patients who got sort of attention controls. They got like 10 visits or something. So they got like a smaller dose than the dose you were imposing in capable. So think about it this way. Instead of capable versus nothing, it was capable versus a small dose of capable. And that showed no cost impact. Well, one might infer there probably is a cost impact from compared to nothing. And that's probably an important context I failed to make clear, even though staff put it on the slide.
Well, sorry, and if I can just also interject, actually the cost results for that we still don't have. The staff at CMS are working on the cost for the randomized controlled trial. The costs that are published are the one-arm trial from the CMMI demonstration project. But it is true, that the attention control group, they had 10 visits. They were also goal-directed, also about what they wanted to do, but it was sedentary goals. And so some people criticized that as being too strong. And that group did improve to an extent. And when you say that we didn't keep improvement at 12 months, that was in comparison to that social group. But they were still improved compared to their own selves at the beginning.
Are there any other questions from the commissioners? If not, let's go to the portion of the hearing where we hear from public commenters. We have 6 that have registered, but it is open for others. There is 1 that is on site, and remind the public commenters that you're limited to 3 minutes. And the first one is Sharmila Sandhu. Oh. I'm being prompted that you all can sit back there. Thanks.
Hi, good morning. Thank you for the opportunity. My name is Sharmila Sandhu. I'm the Counsel and Director of Regulatory Affairs with the American Occupational Therapy Association. I'd like to just make a brief comment. The American Occupational Therapy Association is the national professional association representing the interests of more than 213,000 occupational therapists, occupational therapy assistants, and students of occupational therapy. The client-centered, science-driven, and evidence-based services of an occupational therapy professional enables people of all ages to live life to its fullest by promoting participation in daily activities. We appreciate the opportunity to provide feedback on the Capable model. The program evolved and developed through a series of studies and has clearly demonstrated the importance of addressing Medicare and Medicaid beneficiary problems related to everyday functioning and the home environment, which are both specific domains within the scope of occupational therapy practice. Capable has resulted in reduced disability and healthcare cost savings while promoting aging in place, outcomes which are increasingly desired by elders and their families as the baby boomer population continues to age. Capable interventions are consistent with the perspective, role, and scope of occupational therapy practice in community health and prevention. The skilled occupational therapy perspective is integral to the fidelity of the Capable intervention. Capable promotes safe and effective aging in place to positively impact population health, while at the same time meeting the unmet individual Medicare beneficiary needs that directly drive healthcare costs, but are not readily addressed in current care or reimbursement models. Capable also is directly aligned with the goals of the triple aim, in our opinion. As a national professional association representing occupational therapy, AOTA asserts that the demand for these types of targeted, coordinated services for the Medicare and Medicaid population will only continue to grow. The inclusion of housing and home modification considerations is critical at a time when payers, policymakers, and quality experts are recognizing the importance of social determinants of health or social risk in the overall health risk profile and recovery trajectory for patients. Services like Capable, which demonstrate reduced healthcare costs and health utilization through innovative preventative interventions, offer the potential to greatly impact both the individual recipients and population health, as well as the caregiver needs for those beneficiaries. AOTA continues to believe it is critical to weave key social determinants of health into the fabric of healthcare coverage and payment if we wish to truly and be more responsive to the needs and wishes of the elderly population. That's all I got. Thank you.
Thank you. We have on the phone now Samantha DeCoven.
Thank you for the opportunity to participate. This is a great conversation. I'm with Brick Partners. We're a consulting and project management firm in the Chicago region, and we're supporting a Capable replication among our partners here at the Northwest Housing Partnership, which is a housing organization that delivers a range of housing services, and their partner, Attuned Care, which is the home health agency that has on staff an occupational therapist and RN who participated in the training and are delivering this program to clients. Another important partner for us is the Metropolitan Mayor's Caucus, because this effort was really led by municipalities who said, we're concerned about our residents and we're seeing burdens on our first responders and our social services as we have an aging population and our residents wish to remain in their community and remain in their homes and be able to live independently. So this small demonstration is in the northwest suburbs of Chicago. We're underway, so I can't speak to any of the data, but I can tell you that in conversations and in early reporting, our clinicians note significant depression and talk about how the participants really benefit from the program and find themselves and report themselves more able to do the things that they wish to do. The handyman comes out sent by the housing organization and is able to do the minor repairs as well as providing some of the tools and other needs identified by the client with the occupational therapist. And our clinicians really talk about the benefits of having been trained and focusing on the client-centered approach to delivering care, and that it's a tool and an approach that they are able to bring into their other work and be able to speak to how they are benefiting from the training. There's a lot of interest around the region. The Metropolitan Mayor's Caucus has surveyed municipalities, and the communities around the region identified aging in place and helping their communities with an aging population as top priorities that the municipalities want to identify. So there's a lot of interest in growing and scaling this program, and so we're eager to see you identify sustainable funding mechanisms so that we're able to replicate this program locally. Thank you.
Thank you. And now, is Amanda Goodenow on the phone?
Yes, I am. So I'm Amanda Goodenow. I'm the occupational therapist and the program manager in the Denver area. I work at the Colorado Visiting Nurse Association. We are a home health agency. They're implementing Capable. We do have separate OTs and nurses that only do Capable. So we do both Capable and home health services, though, also. And it has, like Sarah has said, has been challenging to get into the Capable mindset versus the home health mindset. But with a lot of work and time, we were able to transition, and we are thriving. We have seen about 126 clients so far in the Capable program. And I just wanted to give you some clients' perspectives of the program. We had one gentleman that his main goal was he wanted to be able to get in and out of the house safer. He really wanted to be able to get to his AA meetings. He was a recovering alcoholic and drug addict. And just by the simple modification of rearranging the way the door swung open to get into the garage made it feasible for him. And that's not something that he had thought of previously, but through the OT's expertise and with the work of Habitat for Humanity of Metro Denver, he was able to have that done. We also had a gentleman who, kind of like Sarah has talked about, was stuck in his house for years. He was wheelchair bound and did not have a way to get in and out of the house. In order to get to appointments, he would have to have people lift him up in the wheelchair to get down the stairs or go via ambulance, which, as we know, is extremely expensive. So we were able to build him a wheelchair ramp, and he just started crying because it was the first time he was able to get himself in and out of his house. Not only is it feasible for him, but now it's also a safety improvement in case of fires and things like that. We at the Colorado and VNA have noticed some significant changes in depression, increased independence in ADL, decreased pain, and decreased fall risk. Some of the data that we have pulled ourselves, we do the PHQ-9 right before admission into the Capable program, and then after the Capable program has been implemented, we do it again. And we've noticed a 57% decrease in depression. We've noticed an increase in independence with ADL by 77%, and pain has improved by 53% in the little bit of data that we have pulled ourselves. So overall, we at Colorado VNA have shown some major improvements in these clients. The other thing that we have noticed is just community reentry. A lot of people are getting back out into the community, so they're no longer just staying at home all day and isolating themselves. I had a client personally that she had fractured her humerus, and we as a home health agency had actually seen her from home health, and she had progressed through the home health side of things and was discharged to outpatient therapy. So she then qualified for the Capable program, and she really wanted to be able to drive her car, but it was a standard, and she broke her right humerus. So shifting the standard wasn't feasible for her at the time. So she started towards the end of the program actually calling friends and getting rides, which previously she thought that was a burden. But through the program, without us even addressing this as an issue, because this was not one of her goals, through the program, she started reaching out for help, which is fabulous. It shows those behavioral changes that occurred through time. She was then going to cards once a month with friends and back to her book club once a month with friends, which is just absolutely huge. The other thing we've noticed is people getting involved in going to the senior center for different activities or getting involved with Silver Sneakers. Again, these aren't necessarily their goals. These are just some of the outcomes that occur as a side note of the program. So we have thoroughly enjoyed implementing this program, and as an OT, it's really fun to be able to see them over this expanded period of time. It's only 6 visits, but you truly get to see major change because it's not 6 visits in 3 weeks. It's 6 visits over 4 to 5 months, which has been really, really nice, and it's been a joy to be able to implement this program. Thank you for the opportunity to speak.
Thank you. Is there anyone else on the phone or in the audience who would like to comment at this time?
Produced by the U.S. Department of Health and Human Services at taxpayer expense.